everyone to our third ECHO session. We are honored to have our pediatric neurologist, Dr. Catherine Christie, who's going to be leading the discussions during this session. And for you all joining us, I would love for you all to say hi and say who you are and where you're joining us from. So if we could start with Gayatri.
Hi there, I'm Gayatri J. Shankar, a general pediatrician with ETSU Pediatrics. I didn't sign in as ETSU Pediatrics, hoping not to confuse everyone, but I'm going to be presenting from a patient from our clinic.
Great, thanks.
I'm Maggie Quinn. I am a pediatric nurse practitioner in Lenore City, south of Knoxville. Oh, with Cherokee. I'm with Cherokee.
Awesome. And Dr. Bradley?
Jeremy Bradley, a pediatrician in Bristol, Virginia. And I got a Quillen student with me.
Oh.
Hey, Jeremy.
Student doctors and ETSU Family Medicine.
We have Diana Hyman and a couple of our residents here that are joining us. There'll probably be a couple more that wander in. So thank you for having us today.
And then Dr. Rogers and
I'm going to speak for Dr. Rogers because her microphone is not working. Amy Harden and Dr. Rogers were actually in our own separate offices in the same building here in Marion, Virginia with Mountain View Pediatrics.
Great. And what about Highlands Pediatrics? Or Dr. Wallace?
Hi, Dr. Wallace, T.P. Wallace from Cherokee Health. I don't know why my picture's not coming in, but at any rate, we'll be here.
Great, we can hear you, thank you. What about for SOPA Peds?
Yes, we're here.
All right, great, glad you're here.
And I just want to introduce Ali Fort, one of our medical students who's also joining us today with a presentation
All right,
from ETSU.
great. And Dr. Carroll? Oh, I can't hear you. Unmute.
Oh.
Okay.
Okay, I'm Hannah Carroll, and I've got a student here with me from ET as well, Katie, and we're excited to be here from Cherokee Health Systems.
Wonderful, welcome.
Great, thanks.
And Dr. Wood.
I'm David Wood. I'm at ETSU, but today I'm in Chicago, actually at the American Academy of Pediatrics, and I'm in a very interesting session that's thinking strategically about how to use Project ECHO. And so expanding Project ECHO. So it's really fun to talk about how we can maybe broaden this across our region.
Well, great. We're glad you're here. And just as a reminder for all the participants, please go ahead and register on the CME website so you can get your CME credit. And then in thinking ahead for next month when we have our next session, or actually it's the beginning of March, right? We would love for you to submit cases. So the case submission form is online as well. So we're going to start off with two cases from our own faculty. So Dr. Wood is going to go ahead and present his case first since he is in the middle of a meeting at the AAP. So we'll let him present his case and go from there.
And I will have to, after we have the discussion of this case, I will have to excuse myself. So I apologize for that. But yes, this is a 12-year-old female who just a few months ago, 2 to 3 months ago, started having little spells. They describe it as she spaces out, she stares straight ahead, her eyes seem to maybe squint or flutter, she doesn't lose tone in her body, there's no tonic or clonic movement, she's just there. It just kind of has a spacing out episode, lasting maybe a few seconds, maybe as long as 8 seconds. They haven't really timed them. That they do have noticed that they're increasing in frequency. Sometimes they come close together, and when asked about how many times a day does this happen, they do happen daily, and maybe as many as 20 times a day. Nothing seems to cause it or provoke it. She hasn't had any recent illnesses. She has, in terms of her past medical history, she was a 27-week preemie and attended 2 months months neonatal stay, but really had done well ever since and had no other developmental milestones, were normal, and she really was a well child. We did evaluate this with an EEG, and it did come back with generalized spike and wave pattern, which and with a 4 to 7 seconds, 3 hertz pattern. We didn't do any other workup. We didn't do a head imaging. We didn't do any really laboratory. We're a little concerned because it has really impacted her learning. Her grades have deteriorated over the past year. She also is quite anxious about this. She, because she's gotten feedback about it, she was an A student, but it's really her grades have been slipping. So that's basically an overview of the presentation. And I have some questions about the case. Did I go with the questions?
Sure, go ahead.
So, I mean, it sounds like typical absence seizures. Do you agree with that?
Yeah, so I think we have a little bit of a spoiler alert because we have the EEG results already. But I do think we should back up and think about kind of how we came to that. Because certainly you kind of presented a case of staring spells, and it sounds like maybe some changes in learning as well. I think there's a couple things that are helpful when you have a case like this with staring spells before you get an EEG. And one is, certainly we have teenagers, they're going to stare off. So are little kids. First of all, is that staring spell able to be stopped with tactile stimulation, with actually touching the kid, not waving the hand, not calling the name, that kind of thing? I don't know if the family tried that or not before the EEG was done, but.
Well, I'll just say that, this is based on some other cases as well, but no, when you touch her, she's really out, but then comes back, kind of snaps back. So she's really unaware of what's going on during this entire spell, and she can't be brought out of it by stimulating her, talking to her, touching her in any way.
Right, which I think does raise our concern about seizure. We still, just when we have a staring spell as kind of our primary presenting complaint, I think we still haven't said for sure that it's absence seizures yet at that point. Things also that I like to ask when people have staring spells, we're kind of trying to figure it out, do they stop in the middle of the behavior? So maybe they are playing with toys and they stop kind of mid putting Legos together, those type of things are more concerning to me than they just happen when they're watching TV. Also mid-bite, mid-eating, that seems to be a big one. Most people don't kind of pause with food halfway to their mouth. So those are things when I'm presented with staring spells, which, as you guys know, is a very common complaint from parents and very difficult to tease out sometimes. And those are certain things that I think can kind of help us point us in the seizure or not seizure direction. A couple other things I think are a little bit strange or a little bit different about your case is the age of your patient. I think you said she was 12 or 13, is that right?
Right, 12.
And these have been going on for a couple of months?
Yeah, she had been no history before that.
Okay, so certainly, people don't read the book. And so I think at this point, based on the EEG information that you have, it's pretty safe to call it absence seizures for now. The thing that I would think about with this girl is because of her age, she's a little bit older than we often expect for onset of absence. I would think about, is this actually someone presenting maybe with juvenile myoclonic epilepsy ultimately? So some other questions that might be helpful when you see a kid that's a little older with staring spells, we kind of determine our absence, are not only generalized tonic-clonic, usually that comes up in the conversation if they've had a seizure like that, but also the early morning jerking spells. Kids tend to drop things in the morning. And if they were to have that, that would put us into a different category. And so that would make us think about, this is actually something different. We're going to talk about that a little later in our hour here about that particular syndrome. So for now, I agree with you. I think it's safe to call this absence seizures based on the EEG information that we have. But I do think because of her age, I would maybe think a little extra about it than if she were 8 years old, say, presenting with it.
Would we start her on the typical medicine for that, or would there, because of her age, start her on a different anti-epileptic? Like ethosuximide would be the normal one, but would we start her on a different one?
Yeah, so that's a great question. So ethosuximide, as you know, works really well for absent seizures. In your case, you have that information on EEG that you have the 3 Hertz spike in wave at this point, and therefore ethosuximide should work. That is the pattern that we really need to see for a staring spell that's going to respond to ethosuximide. So I think you're totally safe to kind of start her on that and go from there. There's no age issue with it at all.
One other question. She's having days where she's having many of these. Are you worried about it progressing into some other seizure form or go into like a status? Do we need to have rescue medications? Or is this really just going to be contained within the staring spells and simple medication treatment like ethosuximide?
Yeah, that's a really good question. So when we have kids, I think we all know that absent seizure children, they can have many episodes. Sometimes we don't see them. Sometimes they're having long episodes throughout the day that we don't see. Those should be brought down and to be brought under control over time with our up titration of ethosuximide. It is important, unlike other seizure types, it is important with kids when you are treating absent seizures to repeat EEGs after they seem to be doing better clinically. Because, you know, we always say you don't need an EEG if they're not seizing, you know, treat them if they have a seizure. Absent seizures are an exception to that because often what we see is we get rid of the episodes that we're able to clinically appreciate. And then we're left with many ongoing discharges on the EEG that need more medicine, that are affecting learning, that was brought up in your case for this particular child. And so that is an important piece of treatment of absence epilepsy and follow-up once the medication is started. Your question about a rescue medicine is a really important question because I think everyone has been trained to say a kid has had a seizure, I need to give them diastat, I need to give them some kind of rescue medicine. Absent seizures are an exception to that. If a patient is only having absent seizures, not other seizure types that we're aware of, they do not need a benzodiazepine rescue medicine. And actually, benzodiazepine rescue medicines can cause absent seizures to get worse. So kind of your question about status, it can actually kind of tip them over. So we do not recommend benzodiazepine rescue for absent seizures. Did that answer your question?
How often do you see them going into a status absence, and how do you break that then?
Yeah, very infrequently, usually with IV Depakote, but very infrequently. That has happened, I think, once in the 5 years I've been doing neurology. I've seen it.
Okay.
Anybody else have any questions about Dr. Wood's case or anything that I've said you feel like needs to be expounded on or rehashed?
You talked about titrating up to ethosuximide. Would you start with someone this big and then, or this old, I should say, she's, how would you titrate them up?
Yeah, so it would really be dependent upon how she does at first. So we would recommend starting with a starting dose based on her weight. We'd have to look at it, but a starting dose or a lower end dose, giving that maybe a week or so and seeing how many clinical events she's still having. And at that point, if she's no longer having clinical events, that's when we plan for another EEG. If she still is having, even let's say it gets down to 1 or 2 a day, we still know she needs more medicine, and I'd go ahead and bump her up in a week or 2 if she's still having clinical events to a little more mid-range or low mid-range dose.
Do you check for blood levels, and are you looking for a particular blood level with ethosuximide?
So I'm not. I'm glad you said that. So with 1 or 2 exceptions, there are always exceptions, we almost never use levels in outpatient pediatric neurology. So levels are not very helpful. If the patient is still having seizures, they need more medicine, unless they're having side effects and are unable to tolerate it, and then they need less. So I just go by how the patient is doing, or until I've clearly reached the maximum dosing that's indicated from a pharmacologic standpoint that's recommended, one or the other.
So the maximum pharmacologic is based on a range rather than a blood level.
Correct.
Okay.
Yeah.
Thank you.
Yeah, you're welcome. One of the major side effects also maybe we should mention about ethosuximide before we move on to our next case is that a lot of children will have issues with belly pain when they're taking ethosuximide. It can cause abdominal discomfort. And one of the ways that we get around that, we often start with twice-a-day dosing at lower doses that they can take with food. But sometimes you will have a kid who is doing very well from a seizure perspective on the dose that you have them on, but is having a lot of abdominal issue. And those kids, you can take that same dose and divide it up into TID dosing, and many of them are able to tolerate that spread out over the day, and you can get the same clinical effect. So certainly we try BID dosing. It's a little bit obnoxious to have to take the TID dosing at school or whatnot, whoever the situation is. But the TID dosing sometimes can kind of help a kid that's otherwise not tolerating the dosing BID.
Well, thank you.
Any other questions about the first case?
Well, and what about the age difference? Why is this child at 12 now having is there any structural abnormality, any understanding of why they would be having these later in life? And you initially started out talking about how this might be a form for future or other seizures. What's her likelihood of going on to having other kinds of seizures?
Yeah, I don't know. The only reason that I'm suspicious is that children with juvenile myoclonic epilepsy tend to show up around 12 to 18 versus absence kids tend to show up, more like 8 to 12, 6 to 12, whatever. And that the first seizure type you see in children who go on to be diagnosed with juvenile myoclonic epilepsy is absence seizures. So sometimes a kid, especially a late onset kid, is actually kind of just not yet presented themselves with their true diagnosis. And that's the reason for the suspicion, just because I know that that can be an early sign and her age range kind of pushes her more in that direction.
But you wouldn't see these EEG results in that particular presentation, right?
You would not see them yet, but later on, as we see other things develop, you could see it in the future. You could see some changes in the EEG too.
Thanks.
Yeah. Gayatri had a related case.
Okay, well, we'll go ahead with Gayatri's presentation. Thank you.
Okay. And yes, Catherine, this is a somewhat similar case. I have been seeing this 11-year-old for a while in my clinic. She came in for a well check, and it was an, oh, by the way, she's been having these episodes, and they noticed them for several months now. Family members have reported them. Sometimes school has sent word saying she's having these episodes. They call them staring spells. They say she has no expression. Sometimes her eyes look up to the ceiling. There's no tonic-clonic movement associated with them. There are no tics or anything that she has. They happen for brief periods of time. They can happen several times a week, not necessarily every day is what they say. They say, and I tried to elicit your question about can someone pinch her, can they get her attention, and they haven't tried to physically touch her or pinch her, but they say that she may know what's going on during the episodes. And when you question her, she says, yeah, I sort of remember, I can hear people talking during the episode. Sometimes she doesn't know what's going on is what they said. She's had no incontinence with this. She's had no frank seizures. Her past history is fairly benign. She was a term child, had some severe constipation and dysfunctional voiding, for which she sees Dr. Wattad. He's had her on Ditropan for a while, but is otherwise on no regular medications at all. She was evaluated for ADHD last year, has had some school difficulties, had B's and C's in school and 1 D this past year. She's actually a very quiet child. You would not put her on the hyperactive spectrum at all, but more sort of the attention deficit part of it. There's no real family history of seizures per se. When I asked specifically, Mom said, well, Dad had one episode when he was a child where his tongue rolled back and sounded sort of like a febrile seizure, one-time episode that had never been repeated in the future. And Mom had an episode when she was in hospital one time and was given Phenergan when her eyes rolled back. And I was unsure if it were truly a seizure versus sort of a dystonic episode. So no true family history of seizures that I could elicit. There is some rheumatoid arthritis in the family. There's several members with migraines. there are several members with learning disabilities and school difficulties in the family. She is currently in 7th grade in Liberty Bell. And actually, when she was 9, we had psychoeducational testing done for her because there was some concern she wasn't doing very well in school. And they marked her out as average intelligence at that point. Currently, the school's doing educational testing again. And like I said, she was evaluated for ADHD last year. So I'm sort of stuck with this child. I'm unsure. Her exam is completely normal, by the way. We did her vision. She was 20/20. Hearing was normal. And I'm unsure. They sound like episodes that could be absence, but at the same time, there's some sort of learning issues and things that have been ongoing for a while. I'm not sure if this is just behavioral. Her social history is fairly benign. She lives with mom and a 15-year-old sister. And I've seen her, like I said, for a while. These episodes they've noticed for several months, but they haven't been so out of the way for them to come in for an acute visit. They just brought it up during a well-child check. So I'm unsure of where to go next and what to do with this one.
Yeah, so I think you bring up some really good points. They're actually a little bit different. I think it's a similar case, but has some different points. Because we often get a little confused when kids maybe already have a diagnosis of ADHD or they already have a diagnosis of a learning disability. And I think the issue is you can have both. So you can be having absence seizures and you have ADHD or you do have a learning disability. And certainly teasing out which is which and how much is contributing to what is a big deal. Did you say that her grades, I know she'd had neuropsych testing a couple of years ago. It sounds like her grades have been worse lately or they've always been not very good.
So I think she had a period where they were not very good and she had some testing, but they have also then been worse lately.
Okay, sure. So I think this brings us into kind of a little more complicated in terms of teasing out what is what. The other thing I wanted to go back to is you had mentioned that the family tries to touch her and then they probably say, do you remember what just happened? And she says, yes. And I think this is a potential pitfall as well when we're trying to take histories for staring spells, trying to figure out are they absence, because some of them can be so quick. Some of the episodes can be 2 or 3 seconds long. That can be a clinical event. And by the time it's over, you come and you touch them and yeah, they respond because the episode is actually stopped. So whenever I hear that story, I always ask myself, did they stop because they touched them and so it wasn't a seizure? Or if it's a staring spell, this kind of flavor, I also keep in mind maybe the seizure was just over, or maybe the event was over and that's why they responded. Same thing with kind of remembering it. If you're missing 10 seconds of time, you're going to realize that you missed 10 seconds of time. But if it was a second and a half or 2 seconds and that's all you missed, you may not really have the sense that you have forgotten anything or missed out on anything. I think, certainly staring spells is kind of what brought this into question, it sounds like, and it's always a, oh, by the way, right? But I think that the grades is actually one of the biggest red flags in this story to me and the ongoing learning problems. If you told me this kid was a straight A student, had always been and continues to be, that would be one thing. But looking back on her history, I do wonder, has she really been having episodes like this maybe for years? She's 11 years old now. She's had several year history of learning difficulty. Perhaps that's really what's going on, and whether or not it's just absence and not even learning difficulty, that's one option, or it could be that she has both for sure. And so just like in the case of Dr. Wood's case that we talked about a few minutes ago, I do think that EEG, again, in absence seizures being different than in other types of epilepsy, is going to be very key in figuring this out. I will say that, as we have talked about before, a short EEG, a 30-minute EEG, is probably going to show you enough abnormalities. You're usually going to be able to bring out in an untreated patient episodes of spike and wave that are concerning for absence seizures. When I have a kid that has this many learning difficulties and has this many kind of, struggled this much, this is a kid that even if I decide that, yeah, this is what it is, I'm going to start him on medicine, I might think about at some point doing an ambulatory EEG on this kid, this girl, maybe 24 hours.
What EEG, I'm sorry?
An ambulatory EEG. So an ambulatory EEG is the one, and you guys may all be familiar, that we hook up in our lab. We let it run for a few minutes in our lab, and then we send them home with it. And the purpose is to look throughout the day and really see how often is this really happening. Because when you get into these episodes that are so subtle and it's so hard, you know, when she's doing math homework and she's having to do it over and over and over, you know, I can say, well, at 7 o'clock last night, you were seizing. And that's why, you know, you didn't understand your math homework. So I think that gives us more insight into, in a 24-hour period in a kid in this situation, how much of that is really taken up by abnormal brain discharges and how much of that is not. And I think that gives us a better sense of, you know, only 5 minutes of the day is taken up with abnormal discharges. She may have some learning issues too. Or all day long she was having these abnormal discharges. There's no way I'm going to diagnose her with a learning difficulty at this point. You know, I'm going to treat her.
And it's funny you say that, because mom actually mentioned, I mean, we asked about does she stop midway through doing something? And it wasn't midway through a sentence or midway eating, but she stops midway through homework. And, you know, that always then to me, is it behavioral? You know, you tend to kind of head towards the behavioral piece, but at the same time, that's very interesting that you bring it up, because you wonder, is she seizing and therefore not completing homework? And, you know, how are things going with that piece of it? So that is very, very interesting. So definitely start with an EEG.
Yeah.
And would you do an EEG and head imaging? Is that sort of automatically what you would do?
Yeah, that's a good question. And there's not a perfect answer to that. There are 1 or 2 epilepsy syndromes that sometimes people will say, I'm comfortable with this syndrome and I'm not going to get head imaging. And of those, absence epilepsy is one of them, that people will say they have the EEG pattern, they responded to the medicine, you know, we're just going to go forward. I'm kind of on the fence, maybe because a lot of my patients turn out to be something else. You know, I don't just see straightforward, it worked and we're okay. If a patient really does respond, if it really does seem classic, sometimes I will just start and see, do they respond to ethosuximide? Does it fix it, etc. If it doesn't, if they're having a hard time, I do go ahead and pursue head imaging, because again, sometimes it's not exactly what it seems. I wouldn't necessarily rush into doing it. I think you would be okay to start with the ethosuximide and then to kind of go forward and see how she does. Does that make sense?
Yes, definitely. And I know for a fact school is doing psychoeducational testing, but in somebody like this where both are a question, would you do the EEG and push for testing? Is that something that you automatically do?
Yeah, that's also a great question. This comes up a lot in my clinic too. I would do the EEG. I would try to say yes or no, we're having seizures. If it is absence or some related entity, I would treat that first. I would try to clean up the EEG. And then if we're still having learning issues, then I would do testing. Because I just feel like it's unfair, you know, if you're half treating seizures and you're having them also, you know, tested at the same time. So I tend to tell families when they ask me to try to delay it until we've kind of cleaned up the EEG, to give them a real fair chance to get a baseline.
I think that's fair, yes.
When we're talking about imaging, can you help us decide, how do we decide when we're doing contrasted MRI versus uncontrasted MRI? Can you speak with that for just a minute?
Yeah, absolutely. That comes up a lot and is a really good question. So when I'm imaging someone for epilepsy, they've come in, they've had some seizures, I think we're dealing with kind of some sort of epilepsy, I typically do it without contrast. What we're really looking for in the case of an epilepsy patient getting an underlying MRI is to look for malformations of the brain, areas where the gray matter is fatter or whatever that would predispose to having seizures.
So we're muted.
If someone has a seizure or another complaint that makes me concerned about a pressure problem. So for example, if I'm doing a headache, if they have significant headaches and they've started to have seizures, if I'm concerned that they have papilledema on their exam, anything that makes me think there may be something weird here, I will do it with contrast. If you have any suspicion at all that there's a tumor or a demyelinating disease, those cases need to be done with contrast. When we're just doing run-of-the-mill, we need to get an imaging study to look at kind of the underlying brain structure. That can be done without contrast. So in most cases of straightforward epilepsy, needs some imaging without contrast is usually sufficient.
Thank you.
Yeah, that's a great question.
Dr. Pearson had a question.
Dr. Six, this is Dr. Pearson over at Sofa Peds.
Hello.
The initial evaluation of these children, do you ever hyperventilate them in the office to see if you can precipitate a seizure? If you're suspecting absence, is that something you would do or not, or recommend not? And my second question is on the long-term prognosis of these children. Do a lot of them outgrow this syndrome eventually? Because it seems like the younger kids that I've had several in practice that have been on medicine for a few years and they were able to come off and be okay from that point on. Would you comment on those two things, please?
Yeah, also great questions. So I do sometimes hyperventilate kids in the office. I have a pinwheel and I'll have them blow on the pinwheel. Another way you can do it if you don't have a pinwheel is to hold a tissue and have them keep the tissue moving. You just hold it out in front of them and have them blow it and keep it blowing. And I have been able to induce it in kids in the office at times. I still do get an EEG so that I have a baseline. Again, is it happening one time when I brought it out, or is it all the time? I kind of need a sense of how often the discharges we're not seeing are happening. But I certainly do try it. I do it with hyperventilation. I encourage them to blow very hard for about 2 minutes. So you have to keep encouraging them because they'll kind of stop. And that adds to my clinical suspicion or diagnosis, but I do go on and get the EEG to see how often subclinical stuff is going on. In terms of, what was the second question?
Prognosis. How long keep on medicine?
Yes. Yes. So in terms of prognosis, about 90% of children with absent seizures will outgrow them. So it is a really good seizure syndrome to have if you're going to have one. And we will typically think about weaning them or considering if weaning is appropriate if someone has gone for 2 years without having any apparent clinical episodes. I always check kids with EEG before we try to wean them for the exact same reason we've been talking about. Are there ongoing discharges we're not seeing? That wean trial is not going to be successful. But most kids are ultimately able to grow out of it about the time they go to high school or before. I just want to encourage everyone to be careful because 10% of them do not outgrow it. And those are the children that are maybe going to present actually as juvenile myoclonic epilepsy or some other form of epilepsy down the line. And some of those conditions are lifelong epilepsy conditions. So it's just a little sad if you told them, you can outgrow it and then they can't. But 90% of them will. So you're exactly right. And your experience is kind of dead on with what the literature shows.
Thank you.
Yeah.
Dr. Sixes. So for this child, does photic stimulation, do I need to order my EEG with photic stimulation? Does that have anything to do with it?
Yeah, so when you order a routine EEG, they will always try to do it with hyperventilation and photic stimulation, and they will try to get them to go to sleep. Those are kind of the 3 things that bring out abnormalities. In absent seizures, we do not expect any abnormalities to come out of photic stimulation in classic absent seizures, but you don't have to tell them, they will do it. I would encourage you though to, if a kid is having a staring spell and that's why you're doing the EEG, the more information that the folks have about why you're doing it, the more they can do the appropriate workup. So if a kid is not trying very hard for hyperventilation, for example, or if they do it once and nothing happens and they know you're looking for staring spell, sometimes they'll repeat it. They may do it a second time later on in the study. So the more information you can give them, all studies are not created equal. So if they know what they're looking for, just like if you know what you're looking for, they can do a better study.
And then in this technology age, is it of any value to have them tape an episode or tape during, use their phone and capture something and give it to you? Should I have them pinch her and see what happens during the staring spell?
Yeah, you can. So videos are always helpful because it's just so much easier to see what they're talking about. Touching is always helpful. It's a little bit hard when the spells are this short. So usually it's bigger spells or longer spells, that's more successful, but you can have them try. So, if she's having back-to-back ones or something like that, they have a warning and they can get them on video. That's always helpful information.
And I actually had a follow-up question related to what Dr. Pearson was talking about. You mentioned following up these kids with an EEG because they may still be having subclinical seizures. How frequently would you order an EEG for them? And then when would you start thinking about things are under control and I want to start tapering?
So I will, like we said, I'll order the first EEG once I feel like clinically things are under control. The first repeat, once we think things are clinically under control. And after that, depends on what the EEG looks like. So if the EEG is really abnormal with subclinical stuff, we'll change the medicine and we'll repeat it 1 or 2 months because, I know I'm concerned. Once I get an EEG that looks pretty good, I'm more likely to just wait till our next appointment in about 6 months. And so the better the EEG looks, the longer I'll wait. We always wait about 2 years for the outgrowing piece, but it is the same. You're going to repeat an EEG before you start any weaning. And sometimes we kind of maybe wean halfway down and repeat another one before we go all the way off of it to see if the abnormalities have come back out once the medicine has gone down. So it kind of depends on how well they're doing.
I have one other question. Hearing the case from Dr. Jashankar, it makes me wonder, in our workups for ADD or workups for learning disorders, how common is it that kids have these ultra short or subclinical absence? Should we be doing an EEG? How frequently? What would be the indication for an EEG in the workup of someone with attention problems or learning disorder? It seems like it kind of brings that up as a potential issue.
Yeah, and there's no perfect answer. The things that, obviously, if there's any kind of staring spells, I would do it because we do know it masquerades. And that's really the biggest one. But anytime a kid comes, occasionally I have someone referred to my clinic for like learning disabilities, which I don't really test for, but I see them and I hear the story. And when I hear, if they come and they tell me a story about decline, that's where I get more worried. So a kid, sure, 6th grade transition's hard. There are other things that could certainly explain trouble or divorce in the family, things like that. But if a kid was doing really well and then suddenly they weren't, or if they do poorly in all subjects. So I also try to get to the bottom of, is it just math? Is it just reading? And has it always just been reading every single school year? Or have we become more pervasive in terms of our trouble? That, to me, is a sign that something else might be going on. If always you haven't been good at reading and every 1st, 2nd, 3rd grade you aren't, but you're expert at math always, I guess it's possible, but their absence seizures don't choose my subject as much. So that makes me less suspicious.
Thanks.
That makes sense.
Yeah, good point.
Other or case-wise on time? Okay. Okay.
All right, we have one more case to present, and that is Ashley, who is one of our 4th-year medical students.
Hi, I'm Allie. I'm a 4th-year med student. I'm going to share a case that came into clinic in December. It's a 14-year-old female. She presented for a first-time seizure. It was a jerking seizure. Mom saw it happen. The patient was getting ready for school. She fell down and was convulsing in all 4 extremities. Her eyes had rolled back, and all she remembers is a little before the event started, she was feeling really twitchy. Then she had a second episode just a week or 2 after that. So this happened twice when they came to clinic. We asked them if there were any other weird events, and Mom said that she's never seized, but she has been really jerky recently. So she's been twitching in her arms. And that is usually just in the mornings that she's noticed that. And that's been going on for about 6 months when she's trying to brush her hair, put her makeup on in the morning before school. The episodes lasted for about 2 minutes, the 2 seizing episodes. Just 2 events total in her lifetime. They can't think of any provoking factors or triggers, but they did notice that both occurred in the morning. So she was started on Keppra at 500 milligrams BID and given Diastat as a rescue medication. No MRI was done, but an EEG revealed 4 Hertz generalized spike in wave burst that occurred randomly and with photic stimulation. No other labs were done. The patient's in 10th grade, no concerns with learning. She's an A, some B student. She's sleeping really well, getting plenty of sleep each night. And so the big question that I have is, do you think this patient represents a diagnosis of JME, or would it just be a second unprovoked seizure needing anti-epileptic medication? And how can we tell the difference?
Okay, I think those are great questions. You said that the jerking in the morning had been going on for about 6 months, is that right?
Yes.
Okay, all right. So I would be highly suspicious about JME, and I think the biggest point of this case is that you guys asked. So the trap I see people fall into is a 15-year-old, a teenager comes to clinic with a first-time seizure. Whenever a teenager presents with a first-time seizure, I recommend that everyone ask kind of screening questions for JME, because, and we'll talk about what those are, because if you don't, you will never catch it. And if you identify that that's what it is, that guides your AED therapy, so you kind of know which ones work, you know the prognosis of the condition, and you can do a much better job kind of starting out on the right foot with managing the patient. So the 2 questions that are follow-up questions I always ask when a teenager has a first-time unprovoked seizure. One is, do they have a history of staring spells? About 20 to 40% of children with JME will show up initially with staring spells, sometimes diagnosed as absence, but not all of them, right? 40% at most. So sometimes that's in the history, sometimes it's not. The second question is early morning jerks. I typically ask it you did a good job with the hair brushing and the makeup. I also ask, does the spoon fly out of your hand when you eat cereal, those kind of things. And often the family will have never heard it because a teenager will ignore that that's been going on. They just, whatever, they're teenagers. And looking back, they'll say, oh yeah, that has been going on for 6 months or a year. A lot of times the family will say, wow, I've never heard that before. And you will know for sure that it is JME. 100% of patients who have JME have myoclonic jerks in the morning. And those myoclonic jerks typically show up before their major generalized tonic-clonic seizure. So really you're looking backwards at it. You just have to know to ask the questions to look back at it. I definitely think that she needs an anti-epileptic, and I think that your choice of Keppra is appropriate. It is our weakest medicine for JME, but it is a medicine that we know works. There are some stronger ones that we also know work if they're needed. JME has a prognosis of basically being a lifelong epilepsy syndrome. It is easily controlled. You really only need one medicine to control it. And so there's good hope that this kid can go on to take medicine, live a normal life, do normal things. But it is not something that we're going to wean her off. We definitely know that she's going to have more seizures if she doesn't have a medicine. The other piece in the history that was very interesting was the photic stimulation that you mentioned on EEG. We had just talked earlier about hyperventilation and absence seizures. JME is a classic induced by photic stimulation. So everyone talks about, the disco ball and everybody with epilepsy and the flashing lights and I can't go to the movies and all of this stuff. That is not true of everyone with epilepsy. And I think it's a little bit sad because we don't tell children with absence seizures they can't go outside and run around, right? And hyperventilation brings on their seizures. So these are patients who actually are affected by flashing lights. So that's something that we often see when we do the EEG. If photic stimulation brings out more abnormalities, those are patients we're actually worried about in terms of flashing lights. So this is a patient, if not on medicine, or medicine is not being taken correctly, where that kind of phenomena could actually provoke a seizure in her. So I think that was a key piece of the history that also pushes me in the direction of JME. Did those answer your question?
Yes.
Anyone else have questions about that case if we have time?
So I had a 16-year-old, and it wasn't in the morning. It was really, she was sitting in the evening doing her homework and then just fell over. But you would say any 15, 16-year-old ask the JME questions no matter what time of the day it happens?
Yes, I would definitely ask. And when you mean the generalized tonic-clonic happened in the evening?
So it was a sort of drop episode.
Okay.
And then she came to, and she was sitting doing homework. The parents were in the other room, so they only heard the thud of her falling to the floor. And then by the time they came back to come see her, she was, up and about. And so I don't think anyone saw her really actually shaking or having a tonic-clonic episode. And she was somewhat confusing in what to do with her.
Yeah.
But you would ask the JME questions for any teenager of that age.
If I think that they've had a seizure or I'm suspicious, I will. It's hard when they don't see it, that kind of thing. The episodes of kind of generalized tonic-clonic or something of that nature, that can happen any time of the day. The stuff that's really the morning is the jerking. And that, almost all the cases I've seen, at least over a couple of months' time, once it kind of really starts, the jerking is more prominent in the morning, the kind of single jerks that they have and drop things.
And phonic stimulation should make you very suspicious for JME.
Yeah, those go together. That makes
one twin who actually went to Kings Island and had her first seizure ever when she went to Kings Island, but that should make you kind of more suspicious then, I guess.
Yeah, the phonic stimulation is pretty classically described with that particular syndrome.
We want to do any other questions before we move on? Great. Dr. Sixty has some slides to review what we just.
We had a quick question.
Okay, one more.
Okay. Would Keppra be your first line recommendation for this syndrome, or would you pick another medicine first?
Yeah. Luckily for everyone, Keppra is a first line medicine for JME. And so it would be appropriate first line. There are people who need a stronger medicine. Some of them don't, but it is an appropriate first line medicine, which is a good point. And I always tell people, if someone is having a staring spell, that you really think is a seizure, if someone is having anything, and you're not sure based on the different types of medicines there are to choose from, luckily for all of us, Keppra covers all of them at least a little bit. Okay, so it covers absence seizures a little bit. It covers JME pretty good, actually. So if you don't know and you can be comfortable starting that medicine, and we're going to talk next session about the medicines in detail, that is the one to go with, because you are at least doing a decent, somewhat job covering almost all seizure types. And if they need something more specific, we can certainly take it from there once they come to clinic.
Okay.
Okay. Oh, great. Catherine's going to share some slides to hopefully pull together everything that we just talked about to really reinforce some of those key points on differentiating some of the common childhood epilepsy syndromes. After that, it'll be about 10 minutes, then we'll wrap up, and thank you all for joining us.
And as we're bringing up the slides, we have slides about the two syndromes we talked about and two other things as well, just to kind of throw out there so you've heard it once. So I'm going to fast forward through to the topics that we did talk about to reinforce that first. And then hopefully we'll have time just very briefly, it's like 2 or 3 slides total, to talk about the others very briefly, just so that you've heard it. So we're going to kind of move through here and come back. So first, let's review childhood absence epilepsy. And I think we've talked about a lot of this today, actually, which is great. Often called petit mal seizures, you may have heard it called that. Typically is going to show up in an elementary school aged kid. Again, older kid, a little bit questionable, certainly can happen. Will often be confused with daydreaming. Often is going to be something that is outgrown. 90% of it, as we mentioned earlier, will be outgrown by about high school. And this typically occurs in a normal developmental child, and they will often be normal development after they're outgrow it as well. So brief staring episodes, they have behavioral arrest. They can happen tens to hundreds of times a day, and they can be very subtle, which is why EEG is much more important to follow in this syndrome than many others. Automatisms, we often talk about lip smacking, picking, eye fluttering, those sorts of things. Whatever the patient does is what they will do. So if they pick kind of with their right hand during their seizure, that's kind of what their pattern typically is. It doesn't change a lot over time. They appear to not have a postictal state, appear to be back to normal, but do be aware that if someone has had an hour's worth of this ongoing discharges, they may be confused at the end of it. So you cannot say 100% that someone after ongoing staring spell who's confused did not have an absent seizure, if that makes sense. So some hints, we've talked about this. Don't wave hands, don't call names, definitely not obnoxious tactile stimuli to try to see if they will pop out of any staring spell. It is brought out by hyperventilation, and pinwheels do work great, or tissues in the clinic. We briefly touched on this. Staring spells are not absent seizures. I think this is such an important point because so many people kind of fall into this pitfall. An absent seizure has a 3 Hertz spike and wave on EEG. It can be brought out by hyperventilation at bedside. There are many other types of staring spells. Many of them are complex partial seizures. And the reason it matters is because ethosuximide treats absent seizures. It does a great job, but that's all it treats. So if you start someone on ethosuximide for staring spells and truly they're having complex partial seizures, you may actually make their seizures worse because you're not treating the appropriate type. So I encourage people, even if you're calling from a clinic or the ED or whatever, if you don't know that it's an absent seizure, just call it a staring spell. Call what you see, what the family tells you, and we can kind of go forward with choosing a medicine that might cover both until we can figure it out. This is an EEG of absence epilepsy. On the right is a normal awake EEG, and on the left is one that has absent seizures. Each green line, they're lines, I don't really have a pointer, but that are 1 second, and what you see is spike and wave morphology. There's 3 of those spike and waves between each of those green lines. That's 3 Hertz spike and wave. It suddenly comes to an end and suddenly goes into an essentially normal EEG. That's the sudden stop that we see at the end of an absent seizure, getting back to normal. Again, note that there are absence epilepsies are not just this kind. There are several kinds actually. Some of them do show up later. Some of them are a little bit different, so it can get complicated. But most commonly is the childhood absence form. Then we did also talk about juvenile myoclonic epilepsy in our last case. It also occurs in developmentally normal children, typically showing up between 12 and 18 years of age. As we mentioned, monotherapy typically is able to control these patients, but it is very important to identify this as a seizure syndrome so we can pick the right medicines. Keppra, Lamictal, and Depakote are the 3 medicines that are kind of the absolute best medicines to treat this particular syndrome. They do often need lifelong therapy. There is some new evolving data that maybe they can outgrow it when they're 70. I'm a pediatric neurologist, so I just say you're going to take it for life. If you're in family medicine, maybe that is a little more relevant, but basically they are going to need medicine for a long time. Diagnosis is based on presence of 3 seizure types. Generalized tonic-clonic typically brings the patient to the physician. And then looking back, you typically will hear a history of myoclonic jerks. That's the hallmark that 100% of patients have, and about 40% have a history of absent seizures as well. Specific triggers, these kids get in a lot of trouble when they go to college. They don't sleep, alcohol consumption, and photic stimulation bring out poor control in kids with JME. So very important that they're taking their medication if these issues are also risk factors. Again, as we've kind of talked about already, absent seizures often show up first, then the myoclonic jerks, then the generalized tonic-clonic. So only looking backward with the correct questions do we really pick out the syndrome. There is a classic EEG pattern, and actually I think Allie's patient had that pattern. It is a 4 to 6 Hertz spike in wave and spike wave pattern. So kind of a variation on what we see in the absence. This is not at all something that if you're not in neurology, you really need to know, but do know that during photic stimulation, we can see a specific pattern, and that does help us reach the correct diagnosis. Because this is the next slide, we'll talk briefly about vitamin-dependent epilepsies and then go back to the other type of epilepsy syndrome I wanted to mention. There are many forms of vitamin-dependent epilepsies. There's no way that could be an entire talk. Vitamin-dependent epilepsies are epilepsies that are, there is a problem in the metabolic pathway of the patient. The most common one by far is vitamin B6 or pyridoxine-dependent epilepsy. You guys may have heard it in intractable seizures in a neonate. You give it to them, they're on every other medicine, they're still seizing, and suddenly their seizures stop. There are atypical forms of vitamin B6 dependent epilepsy. We once treated an 8-year-old who had been in status in the ICU for like 2 weeks, and they stopped seizing with vitamin B6, so it does happen. And there are many other abnormalities as well. The reason I like to point this out is that when I was a fellow, a patient was admitted about 4 a.m. that was admitted by the pediatrics team, and the vitamin was discontinued, as vitamins often are in hospital admissions. And what happened is that that patient had 4 seizures between 4 and 8 a.m. and no one could quite figure out, why the kid had suddenly had so many more seizures. I don't even think they were there for seizures. And we realized that the person putting in the order had omitted the vitamin. So if you have an epilepsy patient, I just always encourage people to be aware that it could be that the vitamins are, it could be they're trying to cure their kid with all these vitamins. These things happen too. But do ask the family, is this a seizure medicine? And if so, it's so important that they get it. So kind of just to be aware of. And then the last epilepsy syndrome, and kind of our looking at childhood epilepsy syndromes that I wanted to mention, just to make you aware that they're out there, are occipital epilepsies. There's 2 forms of them. The first one, despite my husband's coaching, I cannot say, Panayotopoulos syndrome, I'm going to call it. Often neurologists, you'll hear them call it Pantopoulos syndrome. So if you've heard that, that's what they're talking about. And then the second form is Gastaut syndrome, not to be confused with Lennox-Gastaut syndrome. Those are different syndromes. These are epilepsies that arise from the occipital area. The first one, our Greek friend, it occurs in kind of elementary school age, kind of late preschool, 4 to 5-year-olds. And these kids, they will have potentially clonic or tonic activity, but they often have vomiting or retching as part of the seizure. And so I always thought this seizure phenomena was a very interesting one, because we think about seizures and kids often vomit at the end of them, and that's part of a post-ictal state. In this particular occipital epilepsy, vomiting is part of the seizure. So it's a kind of an ictal issue that actually defines the seizure. So when I hear the story about vomiting kind of in the seizure, before the seizure, then going on to have eye deviation and arm movement in this age group, I do think about this syndrome. It is nice to know if they have this syndrome, again, because often they will outgrow it, and that gives us some prognostic, help. The second occipital epilepsy syndrome that we often talk about is Gastaut syndrome. It's a little bit older age group, more like 8 or 9, and they often have visual symptoms. So they can have visual hallucinations, they can have changes in their vision, and a migraine type headache as part of their seizure. So again, kind of an interesting twist, because we usually think about a headache after a seizure as being a very run-of-the-mill post-seizure phenomena. But in this case, it's actually part of the seizure. They will go on and have shaking. They may generalize to their entire body. And again, most of these kids will outgrow this syndrome, so it is helpful to kind of identify it as that. So when I hear a kid that has shaking and they have visual hallucinations, certainly I get referrals that I think, kind of sounds like psych. But if you're telling me that you have visual hallucinations and shaking spells, I'm going to get an EEG to screen and see if there are occipital abnormalities that are kind of making me more suspicious that maybe there's an epilepsy piece. And I think that's kind of it, just going back to what we had talked about before. So if anyone has any questions about any of that, I'm happy to try to clarify anything for you.
Okay. Last call for questions. Great. Thank you all for joining us. I know I learned a lot today. Thank you, Catherine. We are going to continue our neurology topic in the beginning of March, when Dr. Succeed is specifically going to go over medications. And I know seizure medicines have changed a lot since I did my training, and the great question of, am I getting levels? What labs do I follow? When do I titrate up? When do I go down? She's hopefully going to help address some of those. So if any of you all have any great cases or patients that you have questions about, please submit them to us. We'll talk about them during the March session, or any other kind of feedback, just let us know through the CME website. So thanks for joining us.
Thank you.
Okay.
Thanks, Catherine.
Thank you.
Thank you.
Thank you.
Thank you for coming.